So,
Yes, Dr.
yeah, it is a great pleasure to be part of this or organizing such wonderful platform. Saying this, I'm going to proceed to present on the post-conflict revitalization of the health system and mainly focus the case of the integrated health research, which was done by collaboration with different partners in Tigray. As outline, I have introduction, method, result and discussion, conclusion, and recommendation, plus implication for future partnership, as well as the challenge for partnership. Uh, Saying this, when we say post-conflict health system revitalization, it is a process of restoring an armed conflict. I think I'm not going in detail what I mean by the post-conflict health system revitalization. My colleagues abroad, Azeb Gabrasillase, she did a wonderful research, reorienting and rebuilding the health system in Wharton, Tigray. And if you are interested in detail, you can read that paper. It is really amazing. The other paper also, it was done by Haile Abraha Gassasa. Did the impact of war on the health system of Tigray. The health system of the Tigray was severely affected by the war. So in general, when see the stage in the state becomes deteriorate from time to time. After deterioration, the health system becomes collapsed. Then the system, then at this time, the health system will recover from the conflict. And this actually is in a normal scenario. Then the health system move. Okay, work hard to follow for 10 years to reach as a peace and development. Some country political system in Ethiopia extension of from the different to the peace and development. So hopefully we should contribute a lot to reach the peace and development. So here we see the characteristics of the post-conflict health system. Usually it is basically we have a lot of things to be described by the post-conflict health system. Basically, there is insufficient coordination, oversight, and monitoring of the health are integrate most of the 7% of health care professionals. And it increases the spread of infectious diseases. Nowadays, we see a trend of cholera and malaria, especially the trend of cholera and malaria becomes increased from time to time. And the consequence of instability on people ability to get health care and facility. As a result, it's difficult for decision maker to take action. Then due to there is a limited or there is of evidence on what is the need of the community, and it is also difficult to map the health facility and to map the community need regarding the health system. And in light of this, we carried out an integrated health survey. And it was also the major part of this integrated survey. It was published in the East Africa Journal of Health Science. It is a pleasure to have Professor Afar. He is the editor-in-chief for this journal. So that integration of health survey brings cost effectiveness into evidence generation in post-conflict. That is, it is basically the major part. So you can access it for more detailed information. So as integration survey, we have a lot of objectives. The first objective was to determine the use of maternal health service, especially the family planning, ANC, national delivery, and postnatal clinic, because as you see, most of the Tigray was in a better place in most of the health indicator before the war, but as a result of the war, most of the health systems becomes collapsed and it increases inequity and inequality. The other objective also to determine the woman's level of knowledge on obstetric fistula and POP. And we are going also to determine the magnitude of women with obstetric fistula and POP. And we determine the achievement of the integrated measure supplementary immunization activity conducted during the post-war. And we identify the routine immunization among children from 0 up to 23 months of children. And we determine the proportion of vaccine intention and use among adult and health workers for COVID-19 vaccination. Finally, we see it was really shallow and determines the magnitude of net coverage and utilization in the selected districts. So as study area, our study was almost includes all zones except the western zone with the obvious reason, due to the security reason, we do not include the western zone. So here the yellow color indicates the study area for integrated survey. And we carried out our study in 19 districts. Out of the 19 districts, we include 3 tabia from each district, which gives 57 tabia, and from each tabia we select 1 quotient. So SARS to have a representative or SARS to have include a sale for IDP, we include 6 IDP sites from the zonal city of Tigray. So for this purpose, we include 51 districts or 51 questions from the host community and 6 IDP sites, a total of 57 questions. So this research, it was to some extent, it was exceptional. We carried out in an integrated approach. Basically, we integrate our study data was collected from the community, from the host, as well as from IDP. And it also includes from data from the facility, including from health post, health center, primary hospital, general hospital, and the comprehensive hospitals, IDER and AXO. And the survey also covers a range of health area, mainly maternal and child health service, as well as the COVID-19 vaccination. And the most great thing, which gives a great pleasure to be part of this event, we suspect case for the suspected case for fistula and PAP were linked to the near and technical and financial resources were mobilized from diverse stakeholders. For example, technically, it was from Mekelle University, THRI, Tigray Health Bureau, and Mekelle Hamlet Fistula Center. And financially, the fund was obtained from WHO, UNICEF, the NFPA, Moms for Moms, Amref Africa. So for our parameter, for example, for COVID-19 vaccination, we include adult women and men, health workers and health facility. And for the COVID-19 vaccination, we include more than 16 households. Almost 14,000 are for women and almost 3,000 were for men. And we also collect data from health workers about for COVID. And in addition, we include 85 health facility from health post to comprehensive special hospital. And we collect also qualitative data for COVID, particularly for COVID, we collect 6 focus group discussion, 7 IDEA, and 6 KI. And the denominator for COVID was large, then it will also decrease to POP, obstetric fistula, maternal health service, integrated measures supplementation immunization activity, as well as routine immunization. For example, for POP, we include women age of 50 years and above. We include those women above 49 because as age increase, the risk of POP also becomes high. But for obstetric fistula, we include only those who give live births, and we restrict for obstetric fistula from 50 up to 49. So the sample size for obstetric fistula was So for the maternal health service, it is basically the source population was women of reproductive age group from 50 up to 49 years, and the sample size was 10,000. So for the POP, obstetric fistula and maternal health service, we include 51 health facility from health post to comprehensive specialized hospitals, and we include qualitative data also for that one. Especially, we do not carry out a focus group discussion for POP and obstetric fistula. Rather, we conduct for FGD for maternal health service for the ANC, delivery, postnatal, and farm planning. The other issue is the integrated measles supplementation immunization activity. Our target was those children from age 0 up to 59 months and households which children age 0 up to 5 months. So we include a total of 9,044 children. It is an approximate what we call 7,000 households, because one household may contain one or two or some extent 3 households. So for the routine immunization, our target was those children's age from 0 up to 27 months, and we get a total children of 3,111. So for the integrated measles supplementation immunization activity, as well as for the routine immunization activity, we include 72 health facility. It includes from health post to the primary hospital, because most of the immunization carried out from health post to primary hospitals. And for this, we include for focus group discussion, CRI-IDI and CRI-KI. So here we include data, we collect data from national delivery, postnatal, obstetric fistula, and POP. Some extent lengthy, as what we see from other a single survey. So the data was collected using ODK, and it also sent to the Macal University server, and the collected data by ODK was exported for our software for analysis, especially descriptive and advanced statistics was carried out. So as a result, Henry I'm going to present the pertinent findings. Here, the data we obtained from the integrated survey. For example, the fund planning coverage was 28.4%. For the ANC for us, it was 60%. ANC4, it was 33%. Initial delivery, it was 38%, and the postnatal, 20%. So you see the figure, how much the war has an impact in reducing the basic maternal health service. For example, before the war, the farm planning was 36%, but it was decreased to 28%. The ANC for us, it was more than 94. But as a result of war, it was decreased to 60%. The same for initial deliveries. As Tigray, it was in a better place. It shows a remarkable achievement in all his indicators, including the maternal health service. But as a result of the war, most of the maternal health service becomes drops. For example, before the war, it was the initial delivery was 70%, but after the war, it significantly decreased to 38.8%. So as a result, most of two-thirds of the maternal mortality occurred during birth. So as a considerable number of women gave birth at health facility, based on our survey, more than 60% of the women, they give birth at home, at bush, or at forest. So as a result, a study done by a collaboration from different colleagues from Magal University, HRI, which was led by Dr. Awal, the maternal mortality was 840. We are back to 2000. In 2000, DHS, it was 871. Then currently, it was 2020. So it is obvious that how much the war service, it significantly increased the maternal mortality and significantly decreased the coverage of farm planning, ANC, delivery, and postnatal care. So global targets, the Sustainable Development Goal, it was planned to reduce maternal mortality to 70 per 10,000 per 100,000 live births by 23, but we are far away from such target. I think we'll left only just 5, 6 years. So it would be difficult to capture. Rather, we think out of the box. So this is actually the absolute number for obstetric fistula and POP. For research prize before the war, it was rare to find a woman with a fistula and POP. For example, a study done by Moms for Moms and in collaboration with the NFPA and Mali Mercy, the obstetric fistula was 3, which was a study done by Moms for Moms, Mali University, Mali Hamli Fistula Center, and the NFPA in 2015. But after the war, we found that 162 suspected women for obstetric fistula. The same for pelvic organ prolapse. For the study in 2050, it was 31, but currently we obtained 500 pills. So how much the morbidity or the near becomes increased from 3 to 162, from 31 to 523 for obstetric fistula and POP. So the target was for the UN target was to eradicate obstetric fistula by 2030. So it is difficult because obstetric fistula by 2050 it was 1.4 per 1,000, but it was significantly increased to 12 by the study which was found from integrated. So thanks for the Tigray Regional Health Bureau. Based on the lesson taken from the integrated survey, obstetric fistula and POP, and we carried out into in phase 1 and phase 2, and basically we found that 1,174 women out of the 8,000 women confirmed for pelvic organ prolapse, and for fistula it was because as a phase of do you know that the war has significantly in the near miss or the morbidity, and such a manifestation of morbidity also described by POP and obstetric fistula. Before the war, it was rare to find a woman with obstetric fistula, but due to the following the war, the number of women with fistula and POP becomes increased following the war. For example, said that how would you go to health facility? You will lose all your money and gold, karshan or kahan, on something that is not curable. You will not get better, and the health professionals are not God. This is actually 70 years old, record in entry to the IDI participants. How the community perceives about the POP and fistula. So this is actually the image of POP from our campaigns. It is difficult for our women to have such this because someone they live with such a number of such a case of POP for more than 40 years. So it is difficult how the Tigray people, especially the women, suffers from POP and fistula. This is actually some of the our image from our campaign. It is really horrific to see such a woman, especially in Tigray. This is also some of the image from our campaign. It's difficult to see such how our women suffers due to from POP and just this is actually the image for POP. So on which is a vaccination. Here, I try to compare the vaccinations before the war, during the war, basically due to the damage assessment, and the current is for the integrated survey. So the Penta 3, Penta 1, Penta 3, measles and full vaccinated, it is significantly decreased due to the war. Before 5% for Penta. For example, the full vaccination also becomes also decreased due to the war, significantly decreased before. Integrate, basically, we were in a good position in the immunization in the Penta 1, Penta 3, measles, and full vaccination. But following the war, it was really becomes decreased. It is such figure also very illustrative. So the Pentagon, it was decreased from 95.4 to 64. And the full immunization, it was 73% before the war. But based on the finding from the integrated survey, it was 31.4. So it gives a lot of children unvaccinated that high integrate. It's common to see the vaccine preventable disease is common. The disease for comes from the disease from vaccine preventable disease for hepatitis and different problems also becomes prevalent in Tigray. So Pentown, it was has as you compare with before and after the war, 31 Pentown it was decreased by 31%, and Pentasri it was decreased by 42%, and measles one it was decreased by 45%, and the full vaccination it was decreased by 10%. So it is clearly observed that how much the war affects us in the terms of immunization. In addition, we also collected data on COVID-19 vaccination. The average received on COVID-19 vaccination, it was 80.5% among adults, and it was also 90.7% among professionals. Their intention also, it was 81% among adults. It is almost similar. The intention to you for vaccination of COVID-19, it was similar among the adult as well as among the health workers. As part of our integrated survey, we try to compare the cost effectiveness. This is actually the cost, cost limiting setting. The total cost for the unintegrated survey was approximately 33 million. But the cost for the integrated survey it was 11 million. So since we have a limited resource, but we need data for decision making and to maps for the community problems, we try reduce by more than 20 millions. So accordingly, we carried out the test. So the average value for the unintegrated survey was 80 million, but for the integrated survey, it was 2 million, with a mean difference of 5 million. So there was a significant difference in the cost of integrated and unintegrated survey. So the integrated survey was cost effective to bring evidence in a post-COVID setting. This is actually a golden opportunity, or it is a golden opportunity to capture data in resource limiting. So as conclusion and recommendation, since it is a large, huge study, I try to focus mainly on main points. The war had a pronounced effect on it had a significant effect on decreasing the maternal health service, ANC delivery and postnatal care. So as a recommendation, it will be better to strengthen the primary health care. On POP and obsessive fistula, it was the most neglected disease. And for a surprise, we do not capture data on POP from the DHS survey. Rather, to some extent, we capture data on its conception about its treatment. And there is also most of the women, they divorce due to the POP and OF, obstetric fistula So as a recommendation, it will be better to have maternal morbidity surveillance. And here, significant number of children left unvaccinated and under-vaccinated due to the war. So it would be better to strengthen the surveillance on vaccine preventive disease. This is common to see nowadays, the vaccine preventive disease for diseases and different issue in Tigray. And for COVID-19 vaccination, 1 every 5 participants was not vaccinated. Overall, we found that the integrated survey was likely to reduce the cost as opposed to the unintegrated approach. But doing such integrated survey, it needs quality also matters because it will be difficult to carry out a large study, almost more than 5 big research in one. So the quality matters to bring quality data for better decision making. So as implication for future partnership, basically I want to acknowledge for our funders, UNICEF, World Health, WHO, AMRIF, UNFPA, and MAMS. I really appreciate for the Tigray Regional Health Bureau for collaborating such huge integrated survey. And technically, the research was done from Mali University, THR, and Hamlin Fistula Center. So as challenge for the partnership, it was difficult to mobilize the fund from different sources because such a source for the integrated survey, it was mobilized from 6 organizations. And there was also delay in release promised budget, which affects our activity. The budget also limited to has significant effect on it. Also compromise the quality, and especially the approval of the budget at the national level. It also becomes was cumbersome or challenge. So as opportunity, it is better to change the challenge to opportunity. With a limited budget, we try to capture data and we bring data for making. And it's also better to active engagement of partners from the planning to implementation phase. Usually, we try to include partners as the implementation phase. And it is also better to work in multidisciplinary approach. Here, we strongly work collaboratively with different professionals. For example, from medical doctors such as Dr. Muhammad and Dr. Malako, public health, and different health professionals were mobilized to carry out the integrated survey. And it will also better to hunt for local, national, and international grants as we have a limited budget. So finally, I would like to acknowledge funders and our funders, UNICEF, WHO, NFPA, AMRIF, Health Africa, MAMS Forum, and technically individuals Maala Hamli Fistula Center, and for the coordination, the Health Bureau, Maala University, THRI. Thanks so much also for HAIL initiative for giving this opportunity. Thanks so much. Back to you.
Thank you very much, Doctor, for the insightful presentation. Not to chew up on the time of our participants, I would directly provide the floor to Dr. Abenezer for our second presentation. Please, I would like for any inquiries or questions that you have for our Q&A session later on. Once again, thank you so much.
So I proceed, and thank you for the opportunity. I want to thank everyone involved on this program, and thank you for respecting and inviting me for this presentation. So I will just go through some of the main activities and the post-conflict status in the region. So I will not take much of your time. Dr. Muse has eloquently described the researches conducted so far, so I will not go through any additional information regarding to that. So as we all know, Tigray has been in a good health system, had a good health system prior to the war relative to the other regions, as well as if you take it in the absolute terms, in terms of the basic parameters or in the accepted parameters, we are doing good until the war. So the war has a devastating effect, as you all know. So we have conducted a lot of assessments and researches, as Dr. Muse was mentioning, which the research he presented was one of them. So just to give you some how we are accessing the region. So even though much of Tigray is accessible to the health system, there are still significant chunk of the region which are not accessible to the health system, which we have no idea how our people there are dealing with their health issues and how the health system is functioning there. So we can say even though most of them are accessible, still the challenge still pursue, as we all know. So I try to categorize the issues in terms of the health system blocks in the 6 blocks, as we all know, the WHO health building system blocks. So I will begin with overall health system. As you all know, we have conducted an HERAMS assessment, which was conducted almost a year and a half back, and it shows the status of health system. And it was conducted in collaboration with the Ministry of Health, WHO, and also Ethiopian Public Health Institute. And it was the first, actually, after the war, after the peace treatment, the peace treaty, the cessation of hostilities. It was the first major assessment, and it gave us a glimpse of how the Tigray health system was. And it was not good. It was not in a good shape, as we all know. Significant part of the health facilities has been damaged, looted, and some of them has been actually repurposed into camps. So it was really troublesome numbers that we got from the HERAMS assessment. So only like less than 2% was untouched, undamaged, but the rest from partial to complete damage was that was what they have been through the health facility. So this is a number just to give you some graphs. And in the medical equipment is worse because the building may stand still, but yet the medical equipment inside them had been looted. So more than 27% of health facilities has been looted. So when you see the post-conflict situation, one of the most important thing is the leadership and governance, and it's one of the building blocks. And Tigray, due to this current situation, even though there is no active conflict, the aftermaths are still sensible, or they are really affecting the system, as you all know. There is a weak governance and leadership, as you all know, due to the post-conflict and the situation in the region, in the region, not in terms of the regional state, but on the whole Horn of Africa. This have an impact on the health system, as you all know, as we are part of the system. So there is weak governance. One of the epitomes or the strengths of Tigray health system was the strengthening of the government. As we all know, any health initiatives, health ideas used to come up from experts, and they used to be implemented almost overnight at the lowest level of the echelon of power, or the echelon of administration at the areas, or at the lowest governmental apparatus. They used to be implemented because there was a strong government, and yet, but now our strength, that was our strength, but now we don't have that. And these have impacted into poor coordination, lack of accountability, and a lot of mismanagement. The very few resources we get are not being managed well. So this is one of the effects we have. And there is some sort of erosion of public trust to the health system, as you all know. It have a lot of factors, but it may not be today's agenda, but it have impact on that. And the insecurity and political instability also have some impact to the health system, as you all know. We all know that a lot of towns in the region, a lot of zones have two parallel administrators or mayors, and as such, these have significant effect on the health system. So this is something that should take an account. So health system and the human resource, a lot of people has flee, killed, and of course they have been capacitated. And also we have drained our. There is a brain drain, as you all know. A lot of physicians, healthcare professionals overall has immigrated from Tigray. Even though activities are being done to reverse that, but still that is a significant problem in the region in the post-conflict situation. And there is somehow an equal distribution now because a lot of healthcare professionals have vacated their posts at the rural areas and somehow have been merged or uh, they are being collected at the main population centers as a big town. So this is another issue. I will not go through the numbers, but I can assure you a lot of in terms of standard, we still miss a lot of health professionals against the standard, against the need in the ground. So this is the latest assessment we conducted with the WHO. We conducted a healthcare force assessment, not assessment actually, it was census. We include everyone, including not only the public sector, but also the private sector also. So because they are part of it. So nationwide, the poverty line, the poverty rate has increased significantly. The people who fall from the poverty line has increased significantly. Before the war, our poverty rate as a country was, it have drastically dropped to 24%. But now, due to the conflict and the economic shock the nation is facing due to a lot of factors, of course, it have increased to 68%. This is not my number. This is the World Bank's number. The Tigray Statistical Agency actually increased the number for Tigray to about 73%. So 73% of the nations, our citizens are below poverty line, which means it affects everything from the nutrition to the healthcare or to the health system, to the health quality they get. It affects everything. So this is the most important indicator for all social activities, not only health actually. It affects the education system, our water, every social activities being affected by this poverty rate. So we have dropped significantly, and the damage to the health system was significant. The World Bank actually reports about 20 billion to the Tigray conflict, the total damage. But of course, they included some damages to the Afar and Amhara, of course. But well, the number may not. They conducted this assessment during the active war, which may not include the third round of conflict. So the number is expected to be much. But by our experts, we have health economists at the bureau. They estimated by World Bank tools, they have the standard tools. They estimated the total damage was about $3.7 billion, which is a significant number. It does not only actually include the vandalism or the looting, but also the economic loss, because if facility is not giving service, it is a loss. It's not only being damaged, but not giving service by itself is a loss. So that is what I want to add. Our health information management system also had been disrupted, and DHIS2 recently began. So this have affected a lot of things, by the way. A lot of partners, a lot of international and local NGOs could not function because they cannot get they cannot access the data. Data was not available, and a lot of planning was done using some sort of expertise opinions and evidence-based instead of being so this has affected on the post-conflict recovery activities, even though now we are trying to recover it, but still it have significant impact on the last 2 years after the conflict. So when you see the health system delivery, as I mentioned, infrastructure damage was a big issue, and fragmentation of health services because there is a gap in the governance, as I mentioned earlier. There's high burden of disease like outbreaks. I will mention some of the current major burden to the region, as well as there is somehow limited community engagement. It's not that as we used to have. So malnutrition has increased, as you all know. This is actually a shocking number. And we have compared it. I wish I have some time to compare it with other regions in the nation, as well as other regions with other countries. Some Southern Africa, some experts from South Africa came to the bureau, and when he sees this number, he was shocked that he have never seen such numbers in his whole life. He's somehow well experienced expert. So these numbers are shocking. It's really affected. This actually is correlated with the poverty I mentioned earlier. As we all know, poverty is a main factor for malnutrition because the ultimate solution for malnutrition is the economic empowerment of society. So this is what I want to add. This is a starvation assessment by THRI conducted after the suspension of the aid. And one of the most important indicator, maternal mortality rate. As you all know, we have now reached back to 2000, the Gregorian calendar, which is almost 25 years back. And we are back to 25 years in terms of maternal mortality. So this is, I'm trying to elaborate or to show you the context of the post-conflict situation. Cholera, it has been rampant in Northwest. We are lucky that yesterday we have now declared it's no more, of course, but it was a big burden. It's consumed a lot of resources, and of course we have also lost a lot of young citizens on this endeavor. So on this disease, we have been hit by malaria outbreaks, especially the last November and September, and still malaria is rampant in a lot of areas in the region. IDPs uh, uh, our biggest priority as a region was IDPs and returnees. So still we have not returned. We have significant of them have not able to return, which was from the Western Tigray, as you know. So they have added to the already shambled health system. So they are additional burden to the already shambled health system. So I don't want to take much time. This is in Tigrinya, sorry, but just the studies that being conducted. This is what I want to emphasize with about. We all know that the world, we are in humanitarian crisis. We have been in humanitarian crisis. The world have a single pocket, or donors have a single pocket. And every conflict that come up in the world, it is from the same pocket that is being given. Whether it's in Gaza, Ukraine, or in Syria, whatever the nation, or Sudan, it's from the same pocket. So if there is additional conflict, if there is a new conflict, it's from the same pocket that's being drained. So Tigray is no more as topic as it used to be, which means it's have direct correlation to the decrement of the donors' appetite to support Tigray, which we are witnessing actually. Significant partners are phasing out their donors are no more supporting them. So this have really effect on the post-conflict health recovery activities. Because we should have been during the hot time of Tigray conflict, which was on 2021, we were besieged. A lot of donors were giving money, and that money was not coming to Tigray, as we all know, because we are not able to access to this international donor. The whole donation was being siphoned by the federal government. Sorry, it's not like I'm not talking backdoors. It is officially. You can find it on the Ethiopian Humanitarian Fund, AHF. During that period, during the highest or the worst humanitarian crisis in Tigray, which is in 21 to 22, Tigray was a fourth in terms of recipient of the regions from the donors. Oromia, Amhara, and Afar and Tigray was a fourth. That was the time we should be the top one because the Tigray was the only region with the worst humanitarian crisis in the 21st century at that moment. And yet the funds were not being coming here. So we missed that period. Even now, after the post-conflict, after the cessation of hostilities, we are not getting enough because there are additional conflicts in the region, in the nation. It's in Walaga or in Amhara, and also in other regions, in other countries like Sudan, Gaza, Ukraine, and Ukraine was, as you all know, Ukraine war began after our conflict. So as significant, as I told you, the pocket is the same. It is a Western pocket that gives money. To be frank, I think we have to mention this because there is no other countries or donors that are capable enough to cover such amount of money. So that Western pocket is being now stretched thin to cover a lot of conflicts and humanitarian crises across the world. So why I'm mentioning this all, the Western donors have the Western mindset, which they believe in evidence-based. They need an evidence to proceed for their planning for their decision-making process. And if we need that money, we need to come up with a better system studies researches that are palatable. They can something they can accept with. So the research come into picture now. That's why we need more researches and more surveys that are standard, that are led by researchers as Dr. Muse and his colleagues elsewhere, by the tools that are standard, because that's how they believe. HERAMS was significant in the process of donors acceptance, by the way. Before that, we don't have anything. So when HERAMS came, the HERAMS assessment that we conducted with WHO and other big institutions, it was acceptable. So they endorsed that. So if the government and if the tools are acceptable, they can plan accordingly. And this helped to raise funds, to get the donors, to get grants. And this is very important. So that's why today also, as that's what I want to emphasize for today. Researches are really, really important because they make a difference. All the numbers I mentioned earlier are based on the researches conducted so far. So they are very important to strengthen partnerships. Every ambassador or international organization, country directors, or any leaders, every time they visit Tigray, they ask for data, they ask for research. And if you don't have any, we lose that opportunity to support our people. We represent the people, either academic or governmental official. We are out of the people. An IDP mother could not come up with a research or data. The mother there expects us to come up with the research, with the data and with all the appropriate tools that the Western mind can understand. So it's up to us. And that's why I want to emphasize on that. And I want to thank Dr. Muse and his colleagues at the School of Public Health and at IDER overall, who have been very vital for our activities. And thank you for taking much of your time. Thank you. Thank you. Sorry for taking much of your time. Sorry. Sorry.
Thank you very much, Dr. Ebenezer and Dr. Muse, for all the great presentations. I see that we have one question. We are going to proceed to our Q&A session, not to take much of your time. And I would also love to thank you for going through all the session with the patients. I see Dr. Abraha has asked one question, whether we should call it post-war or post-conflict, while huge issues of calamity on board, and there are still sufferings. So how do we see this while considering the various parameters into account? I would give the floor to Dr. Ebenezer or Dr. Muse if they have anything to add on this. Thank you. Okay, so I see some of our participants raising their hands. I think it would be good also to provide the floor to our participants. So over to you, Professor Afwerk, if I am correct. And then Dr. Brook will continue. Thank you so much.
Thank you. Thank you very much, Dr. Haragoin. Can you hear me?
Yes, Professor, it's clearly audible.
Okay, thank you very much, Dr. Muse and Dr. Ebenezer, for your excessively detailed presentations and actually very educational and insightful deliberations. Quite a few questions to both of you. First, to Dr. Muse. Do you see any difference between the host communities and the IDPs in terms of accessing the child and maternal health services? I don't see comparisons between the host communities and the IDP communities. Secondly, you have mobilized a large number of data collectors, supervisors, and of course, research team members. What were the challenge to coordinate such a huge number of people in such endeavors or in such research? Do you expect any impact on your data quality? If yes, what do you do to address this challenge? Third, you have shown us UN's plan to eradicate obstetric fistula by 2030. How about Ethiopia and Tigray? Do we have any plan to eradicate or any plan on OF or on obstetric formula? And lastly, we have seen reductions in many services, in many health services, particularly very many essential health services. But this study was conducted way after the war. So what actually were the reasons? You were mentioning this are due to the war and related issues, but what actually do you feel are the reasons? Was it because of the lack of the healthcare workers or lack of equipments like the cold chain for the immunization, or lack of, because the war wasn't there when you collect the data? This was done before a year, I guess, but the war stopped before a couple of years. So we must have very specific reasons for these reductions, Dr. Musef. My next question was to Dr. Abenezer. I must be honest with you, Dr. Abenezer. You were mentioning about the harams. I'm so sorry. We've got a very good result. I mean, a very good study. I would say even better than the harams. I can say, because there was a damage assessment conducted by Magala University, the Regional Health Bureau, and THRI, which we call it the damage assessment. This is one of the very strong studies that was conducted after the war, I would say, because it has produced papers, very strong papers that were published in Lancet, papers published in BMJ, papers published in JAMA, and papers published in Conflict and Health and others, to be honest. So how come as a regional health bureau, ignored this paper and appreciated harams? We know that it is actually supported by WHO and other people who have got the money, but the Tigrayans themselves, without any money, without any cents from these donors, have produced papers that have informed the globe, that have informed the international community by publishing, in the high leading journals. That's how the issue of, the impact of the war on the health system was known to the world. So it is I would say, a disservice to the people who got involved in the damage assessment. I was expecting an appreciation from the Regional Health Bureau, but you were actually praising the harams study and ignoring the damage assessment, which resulted in the publication of more than 10 papers. The results from I mean, that show the results that shocked the international community. For example, the GBV was done by the damage assessment team. 80% of the health facilities. It was reported before the Herams. That's how the international community get informed. So, and these are not papers that were shelved. They are published in the leading journals across the health sciences. So it's good, Dr. Ebenezer, to address or to appreciate those works from Maghale University, the Regional Health Bureau, and the THRI. Honestly, you might not know, okay, but I think it's good for the Health Bureau to appreciate those efforts. Thank you very much, Dr. Harek.
Thank you so much, Professor.
Hi. I come back.
Yeah,
Hi,
we can proceed, Doctor. Some of the questions forwarded from Professor Afwerk were related to the data quality, about the timing or the state of the war, and also eliminating or eradicating obstetric fistula at a regional level. So you can go ahead and provide your feedback on that, Doctor. Thank you.
Okay, thanks so much. Sorry for the interruption. I think my connection was interrupted. Thank you so much, Prof. I think regarding the data quality, I tried to mention it. Being research is an integrated matter. It needs a quality of data because it is lengthy. The questionnaire was really lengthy, and it is also cumbersome to ask a woman more than 222 items at a single time because it may last more than 1 hour. So it is difficult for a woman to interview such things because you know that during interviews a woman, there might be also some interruption from the relatives or from the neighbors. So, however, since the data qualities matter, we try to provide strong supervision, and we are also provide training for data collector and supervisor. And for a surprise, in our integrated survey, we deploy the data collector from the local health facility. This is basically to follow the women's for obstetric fistula and POP. Then hiring the data collector from the local facility helps us to link the woman to nearby health facilities and to Hamlin Fistula Center. So the issue of quality is really, really matter. I agree with the Prof.
Thank you, Dr. Muse, for providing your... Sorry. Yeah, so I hope, Professor, you have got some responses from Doctor on the inquiries that you had. I think we can proceed to Dr. Ebenezer if we had any reflections on the questions raised by Professor and Dr. Abraha as well. Thank you.
Okay, so thank you. I think it's audible. I will proceed with the questions, and I will begin with Dr. Abraha's question. It is actually the right question. We have been, to be frank, like not struggling, but using the words interchangeably between the post-conflict and post-war. Well, personally, I believe the situation in Tigray is more described had we has been using post-war. But the thing is, especially when related to when we engage with the Ministry of Health and with the federal government, most of they prefer the post-conflict because they say there is conflict elsewhere too. Well, if we go to the legal definition, it may have its own terms or means. Maybe war is between two parties who can declare officially war upon each other and as such. Conflict could be, of course, it could range from small skirmishes into even non-lethal kind of conflict is also part of the conflict. So it's broad, of course, but for Tigray, it was a conflict because we have two stand-alone parties with armies who declare with legal activity. So we can use post-war, but somehow most of if it's civil war, they somehow tend to use post-conflict in a lot of partners that I came across. Actually, I'm sure we are in the middle of a lot of experts here, especially. So they may have say on it. I am just saying, reflecting from my side, from my engagements with other, especially the Ministry of Health, they prefer the post-conflict and well, there could be a right time for Tigray to speak our minds, of course, but now we have to engage with all stakeholders in the nation. So we have been using post-conflict in most of activities. So that's how you should. That's my response. Maybe if we are in the middle of a lot of experts here. I'm sure some of you will have better answer or better understanding of this. But this is from my side. Second question to Professor Afwork. It's the most ambitious assessment conducted. It was during the war. I mean, there was some break in between, but a lot of experts, especially from the regional health bureau, who are actually still asking us to cover for paradigm for that period because all people, all experts have been deployed out of their pocket. They did this assessment out of their pocket with fervor of nationalism and doing for the nation. So it was a big and a very large assessment. It was vital for the bureau. We have been using it and we are still using it, by the way. But the problem is when we have been after the cessation of hostilities and after the Pretoria Agreement, after partners began coming to the region, they ask us the data when we share them that assessment, and they say this is your internal data. That's the main issue was it is the legitimacy or the acceptance by partners and by federal government. So it was so the issue was they want some sort of a standardized as tool they use elsewhere also, some other region and other countries, and also somehow accepted by the federal government. That's why we had to use when we compare it, by the way, to the damage assessment to HERAMS is very somehow low quality in terms of quality, in terms of the questions it have, the way it is conducted is somehow low quality than the damage assessment. But the legitimacy issue comes to the picture. It is conducted by WHO, Ministry of Health, the Ethiopian Public Health Institute, and the Regional Health Bureau. After that, even the findings were very shocking, they hesitated to release it for almost 2 months. They were back and forth communication to release it because it may not show this what they were thinking or whatever they were looking after, but it shows the horrific nature of the health system. So after back and forth, after 2 months, it was officially used and it helped us a lot. It's more like legitimacy, not in terms of the quality of the data itself or the methods it uses. The damage assessment is very comprehensive, and we are still using it in a lot of activities, and we are happy actually. It was published in a lot of journals, so that's the reason. It's not on the expertise, the methods, or it is just the legitimacy issue. And also it does not cover also the third round of conflict, as you all know, which was very damaging, especially in the central and northwestern zone of Tigray. Significant damage happened on the third round of conflict. So that's what I want to say. So I'm trying to use, not I'm speaking as an expert, to be frank, because we all share the same. I think the last question that came ask us about the civil war. What does civil war means? We all know. We have been through this together. We all understand. I'm just using the words that we use with the partners and all stakeholders. So that's why I don't want you to misquote me or misunderstand me. So that's what I want to add. Thank you And if it's not clear, I'm more than happy to come again now. Okay, thank you.
Very much, Dr. Ebenezer, Dr. Minister, for your clarifications on the presentations and the questions that were raised. I see Dr. Brook has been raising his hand, so I will give the chance to Dr. Brook to provide his questions. Thank you.
Okay, thank you. Can you hear me? Thank you for the nice presentation. And also thank you, Hill City, for organizing this channel. And my question is, since most of them is mentioned, I will focus on healthcare financing because one of the building blocks of health is healthcare financing, and one of the goals of is to achieve universal health coverage by 2030. And the current status of Tigray is one of the war affected is the financing system. Before the war, there was community-based healthcare insurance, but currently even either the main referral hospital either has stopped the insurance, community-based insurance. So what's on the pipeline, or what's the plan? Is there anything or any experience from other countries, since most of the around as mentioned by Ebenezer, around 70% of the population is in poverty now. So how can the population get coverage? Did you hear me?
Yes, thank you so much, Dr. Brook. Yeah, I believe Dr. Ebenezer can give us some reflections on universal health, the vision of attaining a universal health coverage despite having such a proportion of population under poverty, and the approaches that are provided in healthcare financing. So over to you, Dr. Ebenezer. Thank you.
Okay, thank you for the opportunity and for I have returned. So yeah, it's a good thing. We have two schemes, as you all know. There is a the social health insurance and the CBHI, the community-based health insurance. Social health insurance have not begun, as you all know. It's supposed to begin some years back before the war, and it should be nationwide. But Tigray was doing good in CBHI, as we all know, before the conflict in terms of enrollment, and especially when we see it was highly impact on the health system. CBHI was very important. And in terms of enrollment coverage, Amhara was the number one actually back. But when we see in terms of the cost and the quality, not quality of care itself, but the number of users per the enrollment was better in Tigray, I think. I'm not the expert here, but that's what I know. Currently, after the conflict, CBHI has been disbanded. All the documents has been lost because we were not documenting, or we were not using a digital one. So a lot of files has been lost. So it have to begin from scratch. So publications are needed. Publication, in a sense, we need to publish registers, the IDs, the CBHI IDs, which is being done. But the most important part is we need a lot of money, and our people at this moment cannot afford the premium, or of course the sliding scale kind of payment is being planned, which means sliding scale in a sense. There is we will categorize the population into three. So people will pay the premium according to their economic status. So currently, in order to begin the CBHI, the region needs 1.2 billion birr. 1.2 billion birr. It's a significant number. And for those who are supposed to be indigent people, for the people who we believe cannot afford to pay, is about 400 million birr. So this is a main stumbling block. We need a kickstart funding for this. The Bureau is like talking to every partner, including we had a high-level meeting with World Bank actually this week. Of course, I'm not sure whether I'm to talk about this on this platform, but the Bureau is doing the best to get this money, at least a kickstart money, so that it will begin to revolve. And when we got that money, I think, and if we try to build people's confidence into the platform, into the scheme, it will somehow improve the health system. So this one I want to say on CBHI. I will not go deep into it because that's not, I think, today's topic, but this is the information I think you believe need to know. Thank you.
Thank you very much, everyone. I think we have taken too much time into the Q&A session as well as the presentations. We are very happy that you've been through all the session. I believe since there is no participant that I see with any questions or who has raised their hands, I would love to wind up this session with a very high appreciation to the presenters, panelists, and those who has invited us, Heal Initiative for Health advocacy team. Thank you so much, everyone. I hope to see you in the next sessions that we will have. Thank you.